Yeah. Good morning to all. I, Dr. K.K. Kalra, on behalf of Dr. K.K. Agarwal, Padma Shri Awardee and President, Heart Care Foundation of India and SIMAO, I welcome you all on this 58th session of weekly roundtable expert meeting. Cumulatively, this is 2543rd session. Dr. Agarwal has been conducting these all educational and training sessions for last 15 months. The moment he is in a hospital, he is fighting with the dreaded corona disease. He is a master of corona and he is fighting the same disease. Let's wish him a very, very speedy recovery. His condition continues as on date.
Sure.
Is better than yesterday. We can say the vitals are stable, and definitely let's pray, and very soon we see him and conducting such these sessions. Today topic for discussion is mucormycosis. With the onset of second wave, although during first wave also very few some cases of mucormycosis were reported, but during this second wave, which is more aggressive and ferocious, many cases of mucormycosis has been reported. First, a spurt of cases are reported from Maharashtra, then from Gujarat, and even Delhi, Gangaram Hospital has reported large number. Even AIMS also has reported recently 10 cases. This is a fungal disease, a serious one, although rare. But during this COVID second wave, large number of cases are being reported from not only from the urban city areas, but from the rural areas also. If we see the fungal spores, including mucormycosis, they are all present in the normal or environment, in the air and in the soil. But in certain conditions, when immune system is affected, maybe this COVID-19 is also, it stimulates the immune disorder. Patients who are diabetic with poor control of diabetes, who are on corticosteroids and having some other comorbidities like malignancies, or they have undergone some transplant surgery or some other, when their immune system is suppressed. So it's very, very high risk in those settings to get this disease. So you are recovering from COVID, but you'll end up in a serious disease, mucormycosis. This mucormycosis may affect your rhinocerebral. It starts from sinuses, then affects the eyes, and then enters the brain. Most common is the pulmonary. It affects the lungs. Then it can be cutaneous, GI symptom, or disseminated also, especially patients of cancer patients or who are on some suppressive therapies. Even in children also, even the newborn, preterms, premature babies, the GI form of this fungal disease is seen. So it's very important to discuss the prevention and early detection of this disease, the rational use of steroids, a diabetic treatment, and judicious use of corticosteroids. Rest, I think we will discuss during the discussion. I request Dr. A.K. Agarwal, who is the ENT surgeon, to chair the session and further now take forward the proceedings of this meeting. Dr. Arun Agarwal.
Thank you, Dr. K.K. Kalra. And before I start my comment, we all are again and again praying for a speedy recovery of our friend Dr. K.K. Agarwal, wishing him discussion. With that start, thank you very much for giving me this opportunity to chair the topic on mucormycosis. The problem is that as ENT surgeon, mucormycosis is nothing new to ENT surgeon. But the fact is that suddenly now it is known to not only ENT surgeon, it is not only to expert, not only to pediatrician. This word is known to each and every member of the society as black fungus. We know it very well that mucormycosis to nose and aspergillosis to lung, two important fungus. If I try to recollect, Dr. Kalra, when we were a student of ENT, the mucormycosis cases were maximally reported from PGI, Punjab, Himachal Pradesh, J&K. There was some geographical distribution, though it was everywhere, but we always felt that this is one of the type of sinusitis because it's getting collected, getting infected, and secretions, and then that leads to some sort of invasive disease. But what happened during this COVID time? This COVID time, which we started globally in 2019 from China, and now it is all over the world. The mucormycosis from China in the month of July 2020. Right? So, but this is in relation to COVID. But then there are sporadic cases. There are cases from all over, even from countries like US and European countries. There were some sporadic cases which were reported from time to time. I agree that India also, during first wave, there were cases. I daughter-in-law admitted somewhere, and then he said, "Doctor, there seems to be a space-occupying lesion. As per MRI, and I need urgent intervention." And then we realized it is nothing but fungus. This I'm talking of somewhere July or August last year. Will become so big in last 1 month. Right? So with this, I would like to also report that there were some sporadic case reports from all over, but suddenly there is mushrooming of cases in the month of April 2021. That particular attack of mucormycosis, is it an Indian phenomena? It's a part of pandemic. Why it is not seen in other countries which were also having equal number of the cases of COVID, maybe in US or Brazil or UK and some of the European countries. Needless to say, the climatic factor, genetic factor, India is diabetic capital of the world. We all know it. And we all know it that we are using steroids in a manner, perhaps at times it is life-saving, but as from pharmaceutical point of view, it is absolutely overuse or overdosing of steroid. And other drugs. As ENT surgeon, I'll be spending few minutes because I must explain to my colleague that this infection, if it is acute inflammation, acute sinusitis, means it gives a symptomatology of the acuteness, fever, redness, congestion, then it is fulminant. And we, as I told you, ROCM. ROCM is rhino, ophthalmic, cerebral mucormycosis. This is the area which belongs to nasal cavity, the sinuses, pen, optic, all around with and the area of pterygopalatine fossa, infratemporal fossa, remaining part of the cerebrum. So these are the areas which are getting involved. ROCM. As Dr. Kalra said, even in younger age group, I'm glad Dr. Kalra informed us about the pediatric age group, which somehow I haven't touched yet. The initial symptoms are fever, perinasal and periorbital pain inside the nose, around the eye, congestion, nasal discharge, and in advanced disease, it goes to nasal ulceration. Necrotic lesion, and ultimately it leads. Regarding predisposing factor, we have already talked diabetes, steroids. Other diagnostic, some of the features which are linked with it is prolonged neutropenia, thrombocytopenia, any such condition of the body which suppression of immunity, maybe post-transplant or some of immunodeficiency disease person is. As when we look into process, diagnostic is endoscopic and function MRI. Vague manner I can also comment, but with this introduction, I would like to invite my other colleagues also to what they feel as a public health approach to mucormycosis or any other aspect they want to touch regarding the black fungus. Dr. Kalra, we can invite our colleagues. Is Dr. Anita there?
No, she is not joined.
Yeah, Dr. Kalra, can I come in?
Yeah,
Yes,
please.
yes, please.
Yeah, thank you,
Yes,
Dr.
Dr.
Kalra.
Ashok.
Thank you, Dr. Agrawal. Again, to begin with, our prayers for early recovery of Dr. K.K. Agrawal, and we definitely are missing his presence here. Secondly, about this mucormycosis, as a plastic and reconstructive surgeon, and having done so many cases of skull-based tumor removal, etc., I want to stress upon this is not an easy surgery to perform. It's a very complex procedure to remove the maxilla, to remove the skull base, orbital floor, and remove the eye, etc. And surgery itself has got high morbidity. And to perform such surgery in a patient which is immune compromised, which has got a diabetic, uncontrolled diabetes, and on top of it, toxemia of other infection, is very, very challenging and should be taken only at a recognized and well-equipped centers which are capable of performing this surgery. Unfortunately, the incidence is happening much more in the rural and semi-rural area rather than coming to the major cities. And we don't find so many cases coming into metropolitan city as much we are seeing in the rural and sub-rural centers. Like in Maharashtra also, it is more into rural-based medical colleges than in the medical colleges in the city. So it's a very challenging new area. And even performing surgery, as Dr. Agrawal said, uh, if it is a tumor, it is easy to delineate a tumor. But if it is a necrotic tissue with fungus infection, it is very, very difficult to delineate the area which needs to be removed. There's a vast area of zone of necrosis, and also the vascularity become very high. So I think it's a big surgical challenge, it's a big learning for most of the surgeons involved in skull base, including ENT and plastic surgeon. And the only thing which I feel to prevent the catastrophe is to prevent the occurrence of this disease. And there, of course, there are so many theories which have been put forward. But again, the personal hygiene, which has been also repeatedly said, wear shoes, wear long trousers, long sleeve shirts, and go while going to the handling the soil, which is the primary source of fungus infection coming here. And also make sure that personal hygiene is included, the proper oral and personal hygiene. Unless we can implement this and repeatedly tell the population in particular rural area, it will be extremely challenging part if the incidence. Now every single day we are getting report that mucormycosis has killed so many people, and it's going to be much bigger killer than any oral tumor which we have been operating. Oral tumor at least does not kill. It can fungate, it can grow outside. And as Dr. Agrawal said, fungus infection is not new. We have also treated so many fungus infections. But the speed and rapidity which is this particular spreading is something very, very alarming for clinician to put their mind to look for an alternative. Surgery is not easy, I can tell you. First option should be intensive medical treatment. And if you can, the surgery should be last resort. But that's one of the considered the safest bet so far. These are my comments, Dr. Agrawal. You can add to the surgical side if you wish.
We may request Professor Shashank Joshi, he is today joined. Please, Dr. Joshi. Any comments?
Yes, I would agree with whatever has been said. In fact, what has happened is in Maharashtra, we are already seeing a deluge of cases. And if you look at the total number of cases reported in Maharashtra, it may be close to around 1,000, 1,500. And now, of course, it has started waning down. We identified 4 or 5 causes of that. One was, of course, uncontrolled diabetes, use of steroids, humidifier, air and water not being sterilized. And there is a remote possibility whether the oxygen, medical oxygen and industrial oxygen, was there any link between the two? That was another possibility. And we have emphasized the need for good oral and nasal hygiene. We also emphasized the need for tight glycemic control for first 3 months post-COVID. The third was to ensure that we need to optimize the use of steroid and use it in the right doses only for the right duration of time. And fourth is ensure that, the sterile water is kept in all oxygenated places. So those were the couple of recommendations we have made. We are also having now dedicated Mucor wards in many tertiary care referral centers, because many of the places are not seeing cases like 1 and 2. Many hospitals have 15-20 patients admitted. Like AEM hospital has more than 20, Global Hospital has more than 15, which is a large number. And today at around 4 o'clock, there is a live workshop by Dr. Ashish Kumkar, who's a ENT surgeon, who's going to conduct live surgeries for these Mucor patients. We have challenges with drugs because you know that liposomal amphotericin B is not very easily available. So already there is a shortage of drugs and something which we need to recognize. So that's about it. We are all praying for recovery of Dr. Agarwal. That's all I would say.
Thank you.
Just to continue regarding the shortage of drug, yes, liposomal amphotericin is a drug of choice, and of course we know it that how nephrotoxic it is. As regard plain amphotericin B versus liposomal, but at the same time, the second drug we all know is posoconazole, which is supposed to be kidney safe, which is supposed to, but unfortunately, what I have been given to understand that some of these drugs are not available in market. Dr. Roy, would you like to comment anything? Dr. Roy?
I have a question to Dr. Joshi. Can I come in?
Yes, please.
Yeah, Ashok.
Yeah. I mean, because you mentioned about the use of sometimes the industrial oxygen or the humidifier, which has been used for giving oxygen, do you think that bottle which contains the humidifier water, we have seen very often in the hospital that they are not, the water and bottle is not being cleaned for days together. Do you think it could be one of the precaution to make sure that the water is changed every day and the bottle is cleaned, or use a sterile saline rather than a ordinary water?
So two things. One is, it's a very good question. We have actually given recommendations to government that we actually don't even need that water. That water is only useful for the patients or the nurses to know whether oxygen is going or not. Otherwise, there is no medical need for that. So in Fortis, for example, Dr. Rahul Pandit, who is on our oxygen committee, told us that in their hospital for the last 5 years, they don't put water at all in those oxygenated bulbs. And you are absolutely right that if at all water is used, then it has to be sterile water or distilled water. And that's absolutely something which is necessary, and it has to be proper hygiene has to be maintained. But most of these cases, as Dr. Agarwal was saying in the past, were from geographic locations. We know we can actually pinpoint these locations. They're coming from Dhulia, Jalgaon, Aurangabad, Nashik. So actually these spots can be located from where they are coming. And so it's difficult to maintain. But one universal finding in most of them is that they all have been having glucose levels between 300 and 400. And probably have not taken insulin, have not managed their sugars well. So it's been a recipe of multiple things. But what you make, Dr. Gupta, is a very essential and important point, that if at all you use the water, you should replenish it and use sterile distilled water. And if that is not available, we have even recommended, government of Maharashtra has recommended boiled water at least, so that at least the area is kept clean and appropriate. Okay.
Thank you, Dr. Joshi. Thank you.
One thing more, just to add, may not be directly related, that the geographical relationship to such type of fungus infection, I will like to take all my colleagues, doctor colleagues, back to their MBBS days. And there is a condition called rhinosporosis. Rhinosporosis, everybody recollect that there is a polyp with cherry-like, strawberry-like picture. And you know what is the most favorite location of rhinosporosis? Odisha. Dr. Gupta, you must be recollecting your MBBS days. Odisha, some of the ponds, some of the lakes of Odisha having very rich rhinos. Anybody taking bath into that pond or anything used to suffer. So definitely, Dr. Joshi, there is geographical predominance of certain type of fungus. But this particular fungus has become perhaps beyond the border of geographical locations.
Actually, I would say when Dr. Joshi also mentioned the first report of this infection came from a Dhulia, from a small, it appeared in a Marathi newspaper by one of my colleagues from Nagpur Medical College. And he reported about 45 cases of mucormycosis. And then there's a series of spread of the disease and cases, etc. So in Maharashtra also it is limited to certain, it started with the small pockets, and then probably it has become a sort of a phenomena which is being seen everywhere. And very, very important point I feel is how to detect it early and how to implement the medical treatment as early as possible. Can it be combined with a patient, those who are diabetic, uncontrolled diabetes, as a prophylactic treatment post COVID recovery phase? Then antifungal can be added, a routine antifungal which is available rather than going for very expensive antifungal treatment. I don't know. I mean, this is not my field, but I was just thinking whether antifungal can be a combined protocol for post-recovery patient with high diabetes.
No, no. So Dr. Gupta, I would like to correct it, and Dr. Agarwal may correct me if I'm wrong. There is no role for prophylaxis. In fact, one of the this is a mold, and it's different from the other types of fungi, and therefore there is no real role of prophylaxis here. In fact, we have made a slide kit. I don't know whether we will have ability to share some screen for our state task force. Maybe I can just go through it very quickly, if some time is permissible. You know,
Dr. Joshi, can you share it? Dr. Kalra, can you share the slides?
If I am provided with the slides, I will share that.
I know that's okay. Doesn't matter. So what we have actually, highlighted what Dr. Gupta is saying is that, prophylaxis is not something which we recommend, that's something which we know very clearly, but we know the risk factors for invasive mucor like trauma, diabetes, steroid use, hemopoietic malignancy, prolonged neutropenia, solid or, stem cell transplant. We know that very clearly. And all we have said is 5 things. And, in that, we have said use of antibiotics and antifungals appropriately, use of clean and sterile water in humidifiers during oxygen therapy, use steroids appropriately, monitor glucose in post-discharge, and monitor hyperglycemia. Don't miss warning signs. Consider all cases of blocked nose as not to be considered as bacterial sinusitis, and be aggressive over there for KOH and microscopy and culture, and don't lose time. And we have said that avoid voriconazole, and what Dr. Agarwal is saying is very correct. Fosconazole or ivaconazole is useful because they are non-nephrotoxic, but unfortunately they are not available. So that's a big challenge which we have.
So at the time of discharge, when a patient, especially who are severe cases of COVID-19 with non-diabetic status, can we advocate it should be routinely before the discharge, thorough ENT examination and deep nasal swab for KOH, smear and fungal culture should be done? Because early detection is the only we can save these patients.
I think it's a good suggestion. They may not be the part of the protocol at present, but since we are getting mushrooming of these cases at the time of discharge, a good ENT examination in terms of nasal endoscopy, which can be done with with all the safety, because the person who is discharged is RT-PCR negative or whatever it is. But of course, the person, ENT or whosoever is doing it, will take all precautions. And to confirmatory, microscopy is the confirmatory. There is no doubt about that. First is the clinical look.
Yes.
And if there is a black kiss surface, that means there is something definitive, but a confirmation is very important. Here, Dr. Joshi and Dr. Gupta, Dr. Kalra, I would like to share with you. Let me also, when we used to treat mucormycosis, we used to treat after surgery with amphotericin irrigation. We used to have amphotericin and tailor-made irrigations. And even the amphotericin gel for local application were also available. And what is going to be the role of that particular irrigation prophylactically, I do not know. But can we think about it? We have to think it now.
What we have, sir, you have very good point. We have recommended is povidone iodine, you know, uh,
Hello.
as a routine in the oral and nasal hygiene. So that's what we have routinely recommended. And many of our ENT surgeons are actually using irrigation of amphotericin.
Actually, I can add during our surgical practice, rather than relying more on the povidone iodine we are also relying on a hydrogen peroxide wash. And in all our surgical practice, to me at least, hydrogen peroxide wash with a copious irrigation has given a lot of cleanness. And that, I mean, hydrogen peroxide is much cheaper and freely available, can also be given as a thing. And my word, one word of caution, which Dr. Agrawal said as a routine for ENT examination in the COVID area, it could prove to be little exposing a young person for close to oral examination, which is the main source of.
Well, of course, so that's why I said
Yeah.
perhaps at that stage when he is COVID negative and
Yeah, I mean that's something worrisome for me.
I know, but हमारे ENT surgeons surgery भी तो कर ही रहे हैं ना. They are dealing with they are the person who are maximally trying to debride.
Yes.
At present, the debridement is going on, debulking, debridement of mucormycosis.
Yes, yes.
And they are doing it at the end of the maybe 20th day or 25th day. But as Dr. Shashank, KEM is having mucor ward, and those mucor ward must be getting some sort of treatment, medical treatment, and many of my ENT colleagues must be operating day and night.
Yeah, Dr. Agrawal, there was a report shared to me by one of my friends, and he said the methylene blue wash and irrigation or a gargle gives a much better protection and oral hygiene than any other thing. I mean, I don't know what is your experience and what is your.
So far, we were using methylene blue only for diagnostic, but for this therapeutic purposes, perhaps all these things I do not deny, and if there is such thing, should be used in a clinical trial manner and found effective. Why not? I fully agree. And I was also wondering that irrigation, you see, when we talk about this particular phenomena, it is the thrombotic phenomena and endothelium damage of vessels within and the fungus is going within the vessel, leading to thrombotic phenomena, and that's why there is dead tissue, and that's why there is damage of the bones and soft tissue. The most commonly involved is the middle turbinate, which is very much seen. If you look into the nose with the naked eye, the most important is middle and inferior turbinate, which is seen. But ultimately, it goes in and around eye, and then it becomes cerebral. So I can imagine what, of course, our recommended treatment, Dr. Joshi, all my colleagues, is surgical and with all loaded antifungal drugs, which are perhaps not available. But this is the right time to think what alternative we can evolve. And in last 3 days, some of our UNT colleagues are working day and night to look into the entire literature and some reports. And perhaps soon they will come out with something. My ENT Association President, who is colleague and friend of Dr. Joshi, Samir Bhargav, he is also working on it. The group from Chennai under Dr. Mohan Kameshwaran, they are working on it. So let us hope in Dr. Kalra, in day or two, we will become more wiser, because it requires, the entire thing has come to you as an attack.
Yeah.
Any role of a regional higher dose rather than giving a systemic IV or systemic antifungal treatment, any role of a regional
मैंने Dr. Gupta से कहा कि a couple of years back I was in US, and one of the very famous rhinologists started his keynote address with amphotericin B irrigation, right? And that irrigation product is available also, But when he started talking about it, perhaps many of the colleagues globally said no, no, no. But ultimately, as per the trials and all, it was found to be effective. So what you said is regional application, regional irrigation is having some role, which we have to, we never knew that we will be requiring this concept to be cleared.
Yes.
Otherwise, we were doing all debulking and debridement surgery. And with the help of person like you, if it is a big one, to take it out to the maximum.
Yes.
Sir, my suggestion is that
Yes.
from the public health perspective,
Yes.
we need to have some robust data which will kind of complement that in which age group, after how much time, after and it has like it has got also predilection for eyes as well. So if we have a robust Indian data, and that will make sure, and with comorbidities, these are all proven facts, but we need to relook at it in this
Yes.
time. So I think that will be very, very important, and so that with whatever people are having this data, so we can look from that perspective. So I feel that Dr. Shashank is also a good morning, Dr. Shashank. So I feel that it will be really very, very nice that some kind of data which is regionally representative, and how is the difference in presentation, what are the different findings of people, so that will be very important.
I fully agree, Sunila, and that's why I said, as regard our ENT colleagues are concerned, they have started working on it. I'm sure the ophthalmic colleague, today we don't have any ophthalmic colleague with us, but yesterday I was hearing one of my ophthalmic colleague also, and each and every concerned specialist has already started working on it. Ultimately, what is I want to share that it is the spinopalatine artery which is being thrombosed, which is the maxillary, internal maxillary artery, which is ophthalmic artery, and most importantly, center artery to retina. And these are the arteries getting blocked, and that is why it is leading to sudden blindness, right? So these are some of the quick observations which are coming up in last 1 month.
So maybe we can have a talk with Dr. Ritu. Dr. Natarajan is also already there, who is very close to Dr. Shashank and all that. So maybe we can have one focal point for
I
eye,
think,
one for
Kalra,
ear,
this is
one
very
for.
important that
Yeah.
even our platform should have some sort of collection of data with some more expert,
I
and
agree. Yeah.
this is important
Definitely, we
because
need more data to form any consensus document, or we say what all as a preventive steps, because prevention
yeah.
is always better than treating this dreaded
Can
disease.
I ask Dr. Gupta one thing, sir? Dr. Gupta,
Yeah.
in the last 1 month, whatever is the cases of mucormycosis are coming, has it come to a stage where plastic surgeon has been involved?
Yes, as a plastic surgeon, because not as a plastic surgeon, but we are getting involved as a skull-based tumor resection.
No,
We
for
have a team.
after this COVID invasion, I'm not talking routinely, but
No, the
in
COVID,
last 1 month.
post-COVID, in
Uh,
these cases,
uh,
our involvement has become like a team of
team.
team as a skull-based tumor resection. But we don't intend to do any reconstructive surgery for a maxillary resection or orbital fluid removal, etc. Because this itself is a patient is not in a stable condition, not in a fit condition to undergo another 8 hours or 10 hours of surgery of reconstruction.
Certainly not.
We
Certainly,
rather say
that's
that
right.
let him live with a defect. But again, as a surgeon, that should be the last resort to go for an extensive resection. This itself is a very major surgery.
That let us not. Let us hope that that stage does not come. Dr. Kalra, your suggestion regarding the examination and the microscopy
Yeah.
before the patient is
It is
discharged is, I think, it's very valid suggestion and should become part of the protocol.
yes. I think, yeah, especially serious patients who have a
Hmm.
prolonged stay in the hospital.
And one can define the prolonged play and the medication.
I'll just, sir, one small comment.
Yes, yes, Dr. Joshi.
Dr. Agarwal and Dr. Kalra, in many hospitals in Maharashtra, not as a part of a protocol, any patient who stays more than 21 days in the hospital, as a routine, they are doing the KOH smear at discharge. They don't do nowadays the COVID test, but they have started doing this. Number two, in many parts of Maharashtra, Dr. Gupta, a lot of oculoplastic surgeons have been involved currently. But the only problem, I must say one more thing, is most of these people with mucor have also very bad lungs. And therefore, they are very, as Dr. Gupta is saying, that they are very poor surgical candidates, even for surgery. And that has been a challenge. And I don't know, but if I can send a link to, we have a live surgical workshop on mucor today by Dr. Bhumkar. And if I can send the link to Dr. Kalra, Dr. Gupta, Dr. Arun Agarwal, everybody, because they all the surgical colleagues are meeting today because they want to formulate some form of a consensus. Because you see, almost in a registry done by the government, they have found almost more than 1,000 cases, and most of them are in medical colleges or they are in big private hospitals. And that's a large number, for a mucor in a month's time. That's a very, very large number, if you ask me. And that's why and most of them are only being managed medically. I'm sorry, surgically, because that's the only thing which is remaining, and that's very sad. So I do buy the point that maybe we need more data to come out with a consensus. I have made one point, so maybe I'll just try to send it to Ashok, and Ashok, you can share it with the group, or Dr. Sunila. And we must then try to evolve something by next week or something, and come out with some guidance from the group that this is what we need to do. And I'm quite certain that next by what is happening in Maharashtra, some parts of North India will also start seeing it. It's just a matter of time, I feel.
It is already seeing it. It is already seeing it.
Last week when we spoke,
Prashant,
some of our colleagues in Delhi,
I mean,
like I spoke to Anup Mishra and all, he said हमारे यहाँ बिल्कुल नहीं है. तो मैं बोला नहीं होगा ऐसा, आ जाएगा.
तो I mean basically
यहाँ पे आता है और वहाँ नहीं आएगा, ऐसा नहीं होगा.
ना ये तो कहना बहुत difficult.
And I also feel strongly that as soon as we get some information, first of all, as per the guidelines, sir, we have got Indian Journal of Clinical Practice, and we have got Journal of Family Medicine Primary Care, and we can also look at the role of family physicians also in sensitizing people. So these articles can immediately go for publication so that people have the knowledge, and Dr. Shashank can also, and Dr. Gupta, you can further guide us as to how we can go further with these points, even if it's a one pager, so that people are much aware of. We should do as part of dissemination of, or maybe it's a kind of a policy recommendation from this group, so that should be published. That is important, I feel, at the end of the day.
Let me share, Dr. Kalra, let me share you the status of Delhi. Delhi, you know it very well that all government hospitals are COVID hospitals. And being COVID hospitals, they are not accepting anything beyond the COVID care, not even the surgical aspect of COVID like. So at present, what is happening, what I observed in a couple of days, that all these COVID referrals are coming to private hospitals, right? And all private hospitals are loaded. And of course, there is expertise in private hospitals, there is expertise in government hospitals. Those expertise are not being used because facilities are not being permitted. So that is why our private hospitals, corporate hospitals are now loaded with this type of challenge. And what I understand, and I have been discussing, that my colleagues are doing a good debridement. They are trying to do their best, not only in Delhi, in city like Lucknow, in Varanasi. Patna AIMS has already perhaps published their own guidelines. Dr. Bhavna is the head. I will try to get those guidelines, which will be perhaps supportive. Even my own ENT colleague, who is the director of Saurav Vasne, is the director of Sunila. Where is this Baidnath Dham in Jharkhand?
Hanji.
What is that place? Very famous place. Right? And he is also working on it. So we will request all my ENT colleagues and ophthalmic colleagues also to join, and so that we can, on this particular platform. And of course, I never knew that Maharashtra has already advanced the collection of thoughts and what Dr. Shashank just now told, that they are having surgical discussions. But my target will be surgical is very important, but can we create something more preventive?
It seems Golghar, sir, or something like that. Golghar?
Devghar.
Devghar, yeah.
The Devghar
Yeah.
AIMS director is my
Yeah.
own ENT colleague,
And
Sunila's
he's
colleague.
a very, very active person.
Very active. So all these areas having enormous number of cases.
And
So by
also, sir,
next
from
week, Dr. Kalra,
Chhattisgarh
I'm sure
also.
Sure.
by next week we'll be having some sort of continuation of this topic.
Okay. Okay. I will
And we so that we are richer as regards the numbers are concerned.
Now, may I request Dr. Alex to give his viewpoint.
No, I think it's been very interesting. I don't think I can add much value to this, all experts here. And it has been good information for me to spread to all our chapters all over the country. Thank you. Very interesting.
Okay.
Dr. Rai?
Dr. Rai, are you there?
Yes, sir. Dr. Rai, I can see clearly.
I think he's muted now.
Am I audible now?
Yes,
Am I
yes.
audible, sir?
Yes, Dr. Roy.
Good morning, everybody. Thank you very much, sir. I think a lot you all have taught us about this mucormycosis. The problem as a general practitioner or information from the patients who are in the hospital, because and this sort of infection definitely requires a continuous observation by the nursing staff. And it is very difficult for a nurse to regularly keep on doing, because when the patients are going, I'm discussing something very common thing which we are facing about, except this one. So what they feel, because once in the morning somebody has come and after they don't bother at all because they are overburdened. I'm not blaming them. So the first thing is anybody, and one drawback is also we are facing. Now there is nobody with the patient in the ward. Previously in general wards and other wards, some attendants are there. If by the way they feel any black spot in the nose or somewhere else, immediately they will call the nurse. Now the patient is not in the position. So I think what we can stress more on this only, as far as the nursing care of the uncontrolled diabetic patient is to be taken very, very seriously. HbA1c has to be regularly checked also. And those persons who are immunosuppressant or immunocompromised patients, they should also be seen. And as far as about the water and other things you had told, it's very right. But this is very alarming because every day we are losing a lot of patients and a lot of panic is there. Only yesterday, 4 patients have been found out in the Meerut and in the Ghaziabad about this disease. We were discussing only about the Maharashtra, but this has come to the UP also. So I think as an expert, whatever we have today discussed, we should immediately draft this one and we should share with the ICMR. Whether they agree or not, we don't mind. But it becomes our duty, whatever we are discussing, these are our recommendations. So, but tomorrow we can say, this expert group informed you 6 months back and today you are discussing. So whatever topic we are discussing, my humble request is, sir, we should pen down, we should give to the press, we should give to the ICMR, we should give to the PMO office and even to the Director of Health Services also and the ministry also. Then only we can say. And second thing is, whatever we are discussing, एक हिंदी में बहुत अच्छी कहावत होती है ना, कि we are doing a lot, but who knows if they are not getting the information. So हमको, I think we should, Dr. Kalra will take care of all these things. As you can depute anybody, whatever we discuss, it should be conveyed to the higher authorities. This is our observation. Thank you, sir.
Okay.
I entirely support Dr. Rai, and I feel that this is the time that all our, the wealth of information which we discuss amongst ourselves by the leading experts in their respective field should be communicated in a proper way, not only to the people those who are sitting in place seat of power, but also to the media, so that even general public also should learn that what is the correct way of doing it.
Yes.
Like what we discuss about the oral hygiene and prevention of these things is very, very vital for the general public to know. Not only this topic, but so many other topics which we have discussed. And I think this is a wonderful idea of Dr. Rai. to have a sort of a committee or somebody, either under leadership of Dr. Kalra and Dr. Rai, they should figure out the points, and that should be released as a press note also to the competent places, and that should have some impact. Irrespective of
Dr. Arun, I would like to come.
please.
Dr. Arun, can I come in?
Dr. Upasana, yes. Dr.
Bijon
Bijon,
Mishra here.
please. Yes, yes, please, sir.
Thank you very much. Thank you very much. First of all, let me tell you that as a representative of the patient organizations in this expert committee, the way you explained in such a lucid manner and the way things were conveyed, it was so easy to understand and comprehend. And I must congratulate you for not only fondly recollecting your college days and the classes where you went, but we also learned today a number of things which made things much clearer in terms of the black fungus and the definitions and how we should be looking at it. The most important takeaway for me today has been that this is an opportunity for us to again rethink and again reinvent ourselves in a manner where we will be able to tackle, not only give advisories and recommendations, but come out with certain very strong implementation plans, in terms of how do we implement them? How do we make sure, that all the healthcare providers are sensitized on this issue? So, Dr. Kalra, as usual, a lot of burden comes on your shoulder because a lot of good things got communicated today. I'm sure you will summarize them and take it appropriately at the right places. And we will collect the data, and I'm sure we will all assist each other in collecting that data, which is very important because that is what is going to help us in the future. With this, again, my prayers every minute goes to Dr. K.K. Agarwal for his speedy recovery. Thank you very much for giving me this opportunity.
Thank you.
Thank you, Bijon. Thank you very much for your kind comments. Dr. Upasana, will you like to comment?
Sir,
Yes.
good afternoon, everyone.
Good
And
yes.
first of all, I wish Dr. Agarwal a speedy recovery. And I am praying every day for him. And I am sending him Reiki because I do Reiki practice. So I thought maybe it could help him. So anyways, today's topic is really relevant. And as a hospital administrator, I realized that it is better, prevention is better than cure. So now I will talk to my team that they should include this, checkup before discharging patient. They should actually do this checkup of ENT and eye. So at least patient should not suffer when he is reaching home and after that he is facing some problem. And Dr. Rai has said that patient should have monitor this HbA1c. So I agree with all the suggestions, and I would like to implement in my hospital. And it is eye-opening. Today, actually, it's a very relevant topic, and everyone is suffering from this problem. And as someone said, I think Dr. Rai said that it is reached to Ghaziabad. So this shows that it is coming to our region also. So we need to be very careful. So thank you so much for all the. Yes, sir. This is this much from my side. Yeah, over to you.
Thank you. Thank you. I think any other comment before we close today's discussion?
Just one point.
Yes, Dr. Ashok.
Just one point I want to add, which Dr. Joshi has suggested. There is no need for oxygen humidifier in the oxygen supply which is coming, and if that can be applied by Dr. Upasana also in our hospital, where we can probably remove possible sources of fungal infection being transmitted in those cases, and that could set a precedence for all other hospitals to follow. This is a very, very important point.
Very important point.
We have found, as our infection control committee in our hospital, there are so many sources of potential infection, and hospital is the biggest museum of infection, and they're all resistant to all hospital, all antibiotic, etc. So we must try to eliminate different sources of potential infection of fungus, and that could be tried in a hospital headed by Dr. Upasana. That's the only thing which I can say. Thank you.
And Dr. Kalra, I would like to give one important comment before I finish, that during the COVID treatment, COVID care, where diabetes is an associated comorbidity, and all our physicians involved in COVID care are perhaps managing the diabetes simultaneously. But my request message will be that the care of diabetes should be given foremost importance along with the COVID treatment. The monitoring of the blood sugar level, which sometimes when I try to inquire are not that, they don't get that much of importance. It's a practical fact. I'm telling you the practical fact.
Practical. Yeah.
So that careful monitoring and management of diabetes is perhaps the key of reducing the number of mucormycosis today in scenario. So, and of course, my really wish that if someone of my person has recovered from COVID, I don't want him or her to suffer consequently with mucormycosis. That is a blow on the medical profession, that after recovering from COVID, the person suffered with some sort of morbidity or mortality because of mucormycosis. So with this aim, back to Dr. K.K. Kalra, if there is no other comment. Dr. Anil, will you like to say anything?
Anil ji?
सर नमस्कार सर.
नमस्कार अनिल जी.
सर थैंक यू सर, थैंक यू. और मैं तो बस आई वाज लर्निंग टुडे एंड इट्स वेरी वेरी गुड टॉपिक. और जो पर्टिकुलरली इसमें मेरा ये कहना था कि बिकॉज इसमें जो मोर्टेलिटी बहुत ज़्यादा है, अबाउट सेइंग दैट 50%, तो आई थिंक वेरी वेरी इंपॉर्टेंट कि हमें अगर पर्टिकुलरली इससे बचना, तो प्रिवेंशन पे जो फोकस है, जो रिकमेंडेशंस हैं, पर्टिकुलरली जो आजकल इरेशनल यूज हो रहा है ऑक्सीजन का और कंसनट्रेटर वगैरह में, उसमें वाटर का जो इशू है कि वो कोई भी कुछ यूज कर रहा है और बहुत लोगों को पता नहीं. तो आई थिंक इज वेरी वेरी इंपॉर्टेंट कि हमारी जो वट एवर द रिकमेंडेशंस फॉर द पर्टिकुलरली प्रिवेंशन, एंड देन अगर कुछ होता है तो क्या ट्रीटमेंट है, क्या अवेलेबिलिटी ऑफ मेडिसिन है. तो दिस वेरी वेरी इंपॉर्टेंट. और आई थिंक ये विल बी हेल्प नॉट ओनली कि हॉस्पिटल्स में लोग हैं जो एटलीस्ट अगर घरों में भी लोग बहुत यूज कर रहे हैं ऑक्सीजन वगैरह का, उनके लिए भी एक अच्छा रिकमेंडेशंस जाएंगी कि बिकॉज वट एवर द प्रिकॉशंस क्या लेनी चाहिए उनको. तो वेरी वेरी इंपॉर्टेंट. मेरा बहुत ज्यादा नहीं कहना सर, इसीलिए
थैंक यू अनिल. थैंक यू वेरी मच. बैक टू यू डॉक्टर कालरा.
हाँ जी सर. थैंक यू सर. It was really a very important topic discussed today, and there is a need for circulation of key points as a preventive measures. Especially is what Dr. Joshi has informed us. Now, this oxygen humidifier bottles are a big source of especially the fungal and other infections. If that humidification bottle is not required for oxygenation, I think this is a very good step. We should dispense with use of bottles, because it is nowhere practical possible at any hospital, even private or a government, to use double distilled water, which is ideally recommended for use of humidifier bottles, or even sterile water. Nowhere it is possible practically to arrange, and people are using simple tap water. So if we can dispense with these kind of things which are unnecessarily not essential for giving this oxygen therapy, I think this will be better. And then especially what we have discussed today about non-diabetics. What about patients who are on irrational use of steroids? They start steroids and they get hyperglycemia, especially in pre-diabetics. Probably those are also group, they are equally at risk And definitely the monitoring of sugar level in every case admitted in a hospital, especially of COVID-19, should be a mandatory. And as discussed, as informed by Dr. Sunila Garg, definitely we need more cooperation, more data to frame a concept paper for circulation. And as proposed by Dr. Arun Agarwal ji, so support from ENT specialist and ophthalmologist specialist will be very, very valuable. And definitely the next time we'll continue with same topic, part 2, with more data as we are able to gather and frame some document regarding prevention and early treatment. I thanks all the participants, especially Dr. Arun Agarwal, who as a who's chaired the session today. And see you again next week, same time. Thank you very much. Thank you all.
Our kind prayer.